Sir, shall we start the session?
Oh, okay.
Good evening, everyone. Little by little, day by day, what is meant for you will find its way. With great joy and immense pleasure, I extend my warm welcome to all the dignitaries, guests, and delegates present here for the Dr. Sudhir Raj N Memorial Free Webinar Series organized by DIKSHA E-Learning in association with Ayurveda College Coimbatore under the banner of Azad Ka Amrit Mahotsav. In today's session, we will be discussing about functional areas of cerebrum and its clinical importance by KrishnaMurthy N.
Before starting the session, I would like to go through a few of the basic instructions to be followed throughout the session. For uninterrupted class session, use laptop with high-speed internet connection. Please make sure your microphone is on mute to have a disturbance-free session. In case of any disruption, please check your internet connection firstly, and if the problem is within our network connection, kindly raise the issue in the chat box. Filling your full name to be displayed is appreciated. Any question can be posted in the chat box. Questions raised will be cleared at the end of the session.
Next, I'd like to invite Dr. Vishnu Ravi Sir, HOD and Associate Professor, Department of Rachna Sharira, Ayurveda College Coimbatore to deliver the welcome address.
Good evening, one and all. On behalf of Ayurveda College Coimbatore and DIKSHA E-Learning, it's my privilege to have been asked for welcoming our guest speaker. As you all know, we have our elegant speaker, Dr. KrishnaMurthy sir, to a warm way of accepting our invitation and for being with us here today. Let me proudly welcome all the dignitaries, practitioners, and students all around the world who have joined with us today. Hope you all get immense knowledge and inspired well enough to spread Ayurveda globally in this pandemic situation. Welcome you all once again. Thank you.
Thank you, sir.
It's a great delight for me to invite and introduce our guest speaker, Dr. KrishnaMurthy N. Sir has completed his UG from Ayurveda Mahavidyalaya, Hubli, and MD in Anatomy from SDM College of Ayurveda, Udupi. Sir has 15 years of teaching experience and currently he is HOD and Professor of Rachna Sharira in SDM College of Ayurveda, Udupi. Sir has published 11 articles and has done 7 paper presentations. He has been a resource person in 8 seminars and has guided 8 PG scholars. Presently, he is PhD, guide, and guiding 3 PhD scholars. We welcome you, sir. We are extremely obliged to have you here, sir. Now, I request Dr. KrishnaMurthy N, sir, to educate us with his immense knowledge. Over to you, sir.
Thank you for my introduction. Now, today we will discuss regarding the functional areas of the cerebrum and its clinical importance. As clinically it is very important, I have chosen this topic regarding the functional areas of the cerebrum and its clinical importance. Is PPT visible?
Yes, sir, it's visible.
Now, let us go towards the first regarding the cerebrum. Cerebrum, actually, it is derived from the telencephalon. Means in the neural tube, a vesicle is there called a telencephalic vesicle, and from that the cerebrum is formed. The cerebrum is the largest part of the brain. It is the largest part of the brain, and it is made up of 2 cerebral hemispheres. It is made up of 2 cerebral hemispheres which are incompletely separated from each other by a median longitudinal fissure. You can see in the diagram that it is incompletely separated by a median longitudinal fissure. The 2 hemispheres are connected to each other. They are connected to each other across the median plane by a commissural fiber called as corpus callosum. Corpus callosum is a commissural fiber which connects the 2 cerebral hemispheres in the median plane. Now, the surfaces of the cerebral hemispheres are irregular due to the presence of sulci and gyri. Actually, it is not smooth. We can observe many sulci and gyri located over the cerebral hemispheres. Why it is necessary? Because they help to increase the surface area of the cerebral cortex. Actually, the surface area is increased by the sulci and gyri. What are gyri? Gyri means that they are the irregular elevated area between the sulci. You can see in the diagram, the elevated areas in between the sulci is called as gyri. You can see here one sulci is there, here one sulci is there. In between the sulci, the elevated area is called as the gyri. And sulcus means a groove lying between the gyri. This is the which is in the depth actually. That is the sulci. The gyri is the elevated part, whereas the deeper part is called as the sulci. And 1/3 of the surface area is exposed as the gyri, and 2/3 lies at the depth of the sulci. You can see that among the surface area exposed, 1/3 surface of the surface area is exposed as gyri, and 2/3 lies at the depth of sulci. 2/3 part will be at the depth of the sulci. Now, regarding the lobes of the cerebral hemisphere, first we will see regarding the division of the lobes. After that, each lobe, we will see the functional areas of each lobe. Now, in the lobes on the superior lateral surface of the cerebrum, when we see, there are 5 lobes are there. They are frontal lobe, parietal lobe, occipital lobe, and temporal lobe, and insular lobe. Insular lobe is a central lobe which is hidden by the operculum of the frontal, parietal, occipital, and temporal. Now, there are 3 main sulci helps in forming the boundaries of these lobes. Which are they? One is the central sulcus. You can see in the diagram, this is the central sulcus. Here, see the cursor of the mouse. This is the central sulcus. Central sulcus begins at the superior medial border. It begins at the superior medial border, about 1/2 inch behind the midpoint between the occipital pole and the frontal pole. So this is the frontal pole, and this is the occipital pole, and in between the frontal pole and the occipital pole, midway in between, about 1/2 inch behind the midpoint, the central sulcus will start. And upper end of the sulcus extends for a short distance onto the medial surface. It runs on the superior lateral surface obliquely downwards and forwards and ends little above the posterior ramus of the lateral sulcus. You can see that it is running downwards here and just ends above the lateral sulcus. This is the central sulcus. See the cursor of the mouse. This is the central sulcus. Next, another sulcus which is important to remember is the lateral sulcus or sulcus of Sylvius. It is a deep sulcus in the anterior and superior lateral surface. Means in the inferior and superior lateral surface. It is located in the inferior and superior lateral surface. It possesses a stem and 3 rami. They are anterior horizontal rami, anterior ascending rami, and posterior rami. Now, in the inferior surface, it will start. This is the inferior surface of the cerebrum. This is the inferior surface of the cerebrum. The stem is located here. You can see the cursor of the mouse. The stem of the lateral sulcus is located here. The stem begins on the inferior surface and passes laterally. Then it passes laterally between the orbital surface and the anterior part of the temporal lobe. So this is the orbital surface and this is the anterior part of the temporal lobe. In between them, the sulci will be passing, and on reaching the superior lateral surface, it divides into 3 rami. See, after reaching the superior lateral surface, it divides into 3 rami. They are the anterior horizontal ramus. See the cursor of the mouse. Anterior horizontal ramus and anterior ascending rami. This is the anterior ascending rami, and another one is the posterior ramus. Another one is the posterior ramus. Anterior horizontal ramus passes forwards into the inferior frontal gyrus. See, this is the anterior horizontal ramus. It passes into the inferior frontal gyrus. And anterior ascending ramus passes upwards and forwards into the inferior frontal gyrus. Into the inferior frontal gyrus, and posterior ramus is this one, which runs backwards and slightly upwards and then turns sharply upwards to end in the parietal lobe. Next, the third sulci to remember is pareto-occipital sulcus. Why I am telling this sulci? Because to know how the lobes of the cerebrum are divided, we should know the sulci. First, pareto-occipital sulcus. This is the deep sulcus present in the posterior part of the medial surface. You can see this is the pareto-occipital. See the cursor of the mouse. See, this is the pareto-occipital sulcus. It begins at superior medial border about 5 centimeters in front of the occipital pole. This is the occipital pole, and in front of the occipital pole, 5 centimeters in front of the occipital pole, the pareto-occipital sulcus will start. And it runs downwards and forwards towards the calcarine sulcus. This is the calcarine sulci. This is the calcarine sulci, and it runs forwards towards the calcarine sulcus. Now, this pareto-occipital sulcus is also important to know how the lobes of the cerebrum are divided. Now, the lobes of the cerebrum, mainly we can observe externally, only 4 lobes we can observe. That are the frontal lobe, parietal lobe, temporal lobe, and occipital lobe. How to demarcate them? Actually, frontal lobe is the lobe located in front of the central sulcus. I told previously regarding the central sulcus. In front of the central sulcus and above the lateral sulci, the lobe which is of the cerebrum which is located is the frontal lobe. The lobe of the cerebrum which is located is the frontal lobe. Now, occipital lobe is demarcated by an imaginary line drawn from the upper end of the pareto-occipital sulcus, to the pre-occipital notch. Pre-occipital notch is a notch located in the inferior lateral border of the cerebrum. Inferior lateral border of the cerebrum is here, and 5 centimeters from the occipital pole, in front of the 5 centimeters in front of the occipital pole, there is a pre-occipital notch is there. And the imaginary line drawn from the pareto-occipital sulcus to the pre-occipital notch will be separating the occipital lobe from the parietal lobe and temporal lobe. In this way, the occipital lobe is demarcated. Next is regarding the demarcation between the parietal lobe and the temporal lobe. Parietal lobe and temporal lobe, the demarcation is done by an imaginary line drawn from the posterior ramus of the lateral sulcus. This is the lateral sulcus, anterior ascending, and this is the anterior ascending, this is the anterior horizontal, and this is the posterior ramus of the lateral sulcus. And the imaginary line drawn from the posterior ramus of the lateral sulcus towards the imaginary line drawn in between the pareto-occipital sulcus and the pre-occipital notch, that will separate the parietal lobe from the temporal lobe. Parietal lobe is located above the imaginary line and temporal lobe below the lateral sulcus and the imaginary line. Below the lateral sulcus and the imaginary line, the temporal lobe will be located, and it is located in front of the imaginary line drawn from the pareto-occipital sulcus to the pre-occipital notch. This demarcation is very important to understand the 4 lobes of the cerebrum. The central lobe is hidden. It is not present externally. It is hidden. That we will see in the next slide. Now, what is the central lobe? Central lobe is also called as insula. It is a sunken part of the cerebral cortex lying in the depth of the lateral sulci and posterior ramus of the lateral sulcus. It is pyramidal in shape. This is the central lobe. It is pyramidal in shape. And during development, what happens is that this part of the cortex grows less than the surrounding cortex. This part of the cortex grows less than the surrounding cortex. As a result, it sinks and is hidden from the view by the surrounding area called as opercula. This is the opercula is the surrounding part which will be covering this central lobe. Now, what are the functions of the central lobe? It is responsible for the present movement awareness, and it controls the autonomic functions by regulating the sympathetic and parasympathetic nervous system. It controls the sympathetic and the parasympathetic nervous system, and this is involved in consciousness and in love and emotion also. Means the limbic lobe is located nearby. One limbic system is there in the cerebrum, which is related nearby and is related with memory, as well as love and emotion also. And the central lobe is also related with that. And it is responsible for the coordination of the articular movements essential for the speech. Why? Because the Broca's area will be located nearby. Broca's area is located nearby. When we remove the temporal operculum and the frontal operculum, we can see that where the parietal operculum, we can see the central lobe, which is hidden under these lobes. Therefore, externally only we can observe only four lobes: the frontal lobe, the parietal lobe, the temporal lobe, and the occipital lobe. Now, let us go towards the functional areas of the cerebrum, the main topic. Functional areas of the cerebrum, we will consider one by one regarding the functional lobes of the frontal lobe, functional areas of the parietal lobe, functional areas of the temporal lobe, and the functional areas of the occipital lobe. First, let us go towards the functional areas of the frontal lobe. Functional areas of the frontal lobe, actually Brodmann, one scientist called as Brodmann, has divided the lobes of cerebrum into 47 functional areas. A scientist named called as Brodmann has divided the lobes of the cerebrum into 47 functional areas. Now, first let us say regarding the functional areas of the frontal lobe of cerebrum. First is the primary motor area. It is the area number 4 in the diagram. Area number 4 in the diagram. It is located in the precentral gyrus. Precentral gyrus and anterior wall of the central sulcus and anterior part of the paracentral lobe. Now, what is precentral gyrus? Precentral gyrus means it lies between the precentral sulcus. See, this is the precentral. You see the cursor of the mouse. This is the precentral sulcus, and this is the central sulci. In between the precentral sulcus and the central sulci, the gyrus which is located is called the precentral gyrus. And paracentral lobule means it is located in the medial surface. This is the superior lateral surface of the cerebrum, whereas this is the medial surface of the cerebrum. Paracentral lobule is located in the medial surface of the cerebrum. It is a U-shaped gyrus around the end of the central sulcus. Around the end of the central sulcus. And anterior and posterior parts of this lobule are the extensions of nothing but the pre and the postcentral gyri. Their extensions on the medial surface is forming the paracentral lobule. Now, this paracentral lobule and the precentral gyrus are the area of the location of the area number 4. Functional area number 4, that is called the primary motor area. That is called the primary motor area. Now, what are the functions of it? What are the functions of the primary motor area? The functions of the primary motor area are, it initiates and controls the voluntary movements of the opposite side of the body. Bilateral control of the muscles of the upper part of the face, tongue, mandible, larynx, pharynx, and axial musculature is also done by it. Now, what happens if lesions occurs in this area? In the primary motor area, if the lesions are formed, then there will be spastic paralysis on the opposite side of the body. Why? Because whenever the upper motor neuron lesion is there, the lower motor neuron activity will get increased. Therefore, there will be spastic paralysis will occur. The masticatory, laryngeal, pharyngeal, upper facial, and extraocular muscles are spared for being represented bilaterally. Usually, the bicep jerk, the tendon jerks, the ligamentum patellae, hit on the ligamentum patellae, the knee jerk, that all will get exaggerated in case of the spastic paralysis. Why? Because this is an upper motor neuron lesion. Next, premotor area. Premotor area or area number 6. It is the area number 6. Now, where it is located? It is located in the posterior part of the superior, middle, and inferior frontal gyrus. Superior, middle, and inferior frontal gyrus, and extends onto the medial surface of the hemisphere. It extends onto the medial surface of the hemisphere. So you can see the area number 6 here. the superior, middle, and inferior frontal gyri, its posterior part, and it is also located in the medial surface also. Now, area in front of the precentral sulcus is divided into superior, middle, and inferior frontal gyri by the superior frontal sulcus. See, this is the superior frontal sulcus. You can see in the diagram, this is the superior frontal sulcus, and this is the inferior frontal sulcus. These two sulci divides the lobes of the cerebrum, the frontal lobe of cerebrum into superior frontal gyri, inferior middle frontal gyri, and inferior frontal gyri. Now, posterior part of it will be considered as the premotor area. Posterior part of it will be considered as the premotor area. Now, what are its functions? It controls the extrapyramidal system. Means mainly origin of the corticorubral, cortico-olivary, and corticonagral fibers occurs from this area. And it also coordinates skilled voluntary movements of a complex sequential nature. Means skilled movements means, for example, threading a needle. It requires a skill. Through the minute hole, we should insert the thread. Now it takes a skill is there to thread a needle. That is done by the extrapyramidal system. Now, lesion of this area will lead to a condition called as apraxia. Lesion of this area will lead to a condition called as apraxia. Apraxia means impairment of the skilled movement without voluntary motor paralysis. Paralysis is not there, but skilled movement is impaired. Means he cannot thread a needle. If you give him a thread and a needle, he cannot threading of a needle cannot be done by him. That indicates that lesion is there in the premotor area. That indicates the lesion is there in the premotor area. The skilled movements are becoming difficult. Next, third functional area of the frontal lobe is the frontal eye field. Frontal eye field is the area number 8. Area number 8. Where it is located? It is located in the posterior part of the middle frontal gyrus. Posterior part of the middle frontal gyrus only. So this is the middle frontal gyrus, and posterior part of the middle frontal gyrus, area number 8, will be located here, just in front of the area number 6, just in front of the premotor area. Now, functions, it controls the voluntary conjugate movements of the eyes. When we look at an object on the medial side or lateral side, at that time voluntary conjugate movements of the eyes will occur. And that voluntary scanning movements of the eyes is done by this. And it is independent of the visual stimuli. The frontal eye field is connected to the visual areas of the occipital cortex by association fibers. Actually, there is a association fiber is there located in between the area number 8 of the frontal eye field with the occipital lobe of the cerebrum. That is called as superior longitudinal fasciculi. One fascicula is there called as superior longitudinal fasciculi, which is an association fiber located in between the occipital cortex as well as the frontal eye field. Now, lesions of the one of the hemisphere causes the two eyes to deviate to the side of the lesion. It will deviate to the side of the lesion and is an inability to turn the eyes to the opposite side. There will be inability to turn the eyes to the opposite side. And involuntary following of moving objects is unaffected since the lesion does not involve the visual cortex of the occipital lobe. But the involuntary movements are not disturbed. Why? Because the occipital lobe is intact, whereas only the frontal eye field is disturbed. If the frontal eye field is disturbed, conjugate movements of the eyeball is disturbed. Conjugate movements of the eyeballs are disturbed. And the two eyes deviate to the side of lesion. The two eyes deviate to the side of lesion. Next, in the frontal lobe, motor speech area or Broca's area, it is area number 44 and 45. Area number 44 and 45. Where it is located? It is located in the pars triangularis and pars opercularis of the inferior frontal gyrus in the dominant hemisphere. Means in right-handed individual, usually it is located on the left cerebral hemisphere, and in left-handed individuals, it will be located on the right cerebral hemisphere. Means what are pars triangularis and pars opercularis? They are the areas located in the inferior frontal gyrus, which are made by the anterior horizontal sulci and the anterior ascending sulci rami of the lateral sulci. The anterior horizontal and anterior ascending rami are there of the lateral sulcus subdivide the inferior frontal gyrus into three parts. The three parts are from anterior to posterior. They are pars orbitalis. This is the pars orbitalis. This is the pars triangularis. B part is the pars triangularis, and C is the pars opercularis part. Pars opercularis. And Broca's area is located in the pars triangularis and pars opercularis area. Pars triangularis and pars opercularis area, they are the areas located in the inferior frontal gyri. Inferior frontal gyri, which are located in between the rami of the lateral sulcus, anterior ascending rami and the anterior horizontal rami, and the posterior rami of the lateral sulcus. Now, what are the functions of it? Functions of it, it produces expressive speech. It is responsible for production of expressive speech, plays a role in the movements of the tongue, lips, vocal cords of the larynx also. Lesion, motor aphasia. Lesion is the motor aphasia, means expressive aphasia will occur. Means he will take too much effort to speak. Effortful, dysarthritic, telegraphic, and non-fluent speech will be there. Means broken speech will be there. If the Broca's area is affected, broken speech will be there. It is non-fluent, and even though the muscles involved are not paralyzed, but there will be non-fluent speech will be there. And they retain the ability to think about the words they wish to say. They can write the words and can understand their meaning when they see or hear them, but they cannot express. But they cannot express. They can comprehend. Comprehend means they can grasp the written speech. They can grasp the written speech, and they can grasp the spoken speech also. Is that grasping power is good, but expression is difficult. Expression becomes difficult in the lesion of the Broca's area. In the lesion of the Broca's area, the expression of the expressive aphasia, it is called expressive aphasia, non-fluent speech will be there. Next is regarding the prefrontal cortex. Area number 9, 10, 11, 12. The area number 9, 10, 11, 12, in the diagram you can see that area number 9, 10, 11, 12 is located in the anterior part of the frontal lobe of the cerebrum. The remaining part of the frontal lobe lying rostral to the motor, premotor, and Broca's and the motor field includes the superior, middle, and the inferior frontal gyri, and the medial frontal gyrus also. The medial frontal gyrus also, you can see the medial frontal gyrus here, there also, and orbital gyri and the anterior half of the cingulate gyrus also. There the prefrontal cortex will be there. Now, what is the function of this prefrontal cortex? This area seems to be important in the development of the personality of the individual. Mainly the personality of the individual development of the personality depends upon this area. It is essential for mature judgment, also concerned with the depth of emotions. Also concerned with the depth of emotions and social as well as moral and ethical awareness also. And concentration, orientation, and foresightedness also, that all is concerned with the prefrontal cortex. Prefrontal cortex. And it is the area capable of associating experiences that are necessary for the production of abstract ideas. Usually, mainly responsible for the personality of the individual. If the lesions occur, let us see the consequences. If the lesions of the prefrontal cortex occur, there is diminished mental faculty will be there, such as negligence, lack of concentration. Here, there will be lack of concentration will be there. Lack of initiative also, lack of judgment. Lack of judgment also. The individual no longer conforms to be accepted by mode of social behavior. This is social behavior becomes not acceptable to others, and he becomes careless, and his dress and appearance because that is inappropriate social behavior will be there, and he is careless about his dress. He is careless about his dress and his appearance also, and he uses obscene language also, and in the public he may urinate also. That means his social behavior is not good. That occurs in the lesions of the prefrontal cortex, area number 9, 10, 11, and 12. Now, this much are regarding the functional areas of the frontal lobe of cerebrum. Next, let us go towards the functional areas of the parietal lobe of cerebrum. Parietal lobe of cerebrum, there is a general sensory or somesthetic area, area number 312. 312. It is located in the postcentral gyrus and the posterior part of the paracentral lobule. Where is postcentral gyrus? You see in the diagram, this is the area number 1, 2, 3, 2, 1, 2. It is located in between the central sulci and the postcentral sulci. See, this is the postcentral sulci. You can see in the diagram, this is the postcentral sulci and this is the central sulci. In between the central sulci and the postcentral sulci, there is the area number 312. And it is also located in the posterior part of the paracentral lobule also. See here, posterior part of the paracentral lobule located behind the central sulci, area number 312 in the medial surface. You can see in the diagram, this is the medial surface of the cerebrum. This is the superior lateral surface of the cerebrum. This is the superior lateral surface of the cerebrum. This is the medial surface of the cerebrum. And in the medial aspect also, it is located. Now, what are the functions of it? Its functions is conscious proprioception of exteroceptive senses, means mainly pain, touch, temperature. Means the Tvak Jnanendriya, what we can say, its perception, pain, touch, temperature, that are percepted here. And also proprioceptive sensations. Proprioceptive sensations means representing the joint sense, whether it is in flexible position or extended position, the joint sense, vibration as well as the muscle sense also, whether it is in contracted state or relaxed state, that proprioceptive fibers will be there, that will be ending here, and that will be percepted from the opposite half of the body. It will be percepted from the opposite half of the body. Now, what happens if the not only that, another posterior part of the paracentral lobule receives the sense of distension of the bladder and rectum. It receives the sensation of the bladder and rectum. You can see here, in this area mainly, it will receive the sense of distension of the bladder and rectum, and the body parts are represented in this way. Means the lower limb is located in the medial surface, as well as the hand and the upper limb will be located in the superior lateral surface. The face located in the superior lateral surface. The body is represented like this in the postcentral gyri. The sensations of these areas will be perceived in these areas respectively. In these areas respectively. The sensations from the tongue will be perceived here, pharynx will be perceived here, teeth and gums will be perceived here, nose, face, lips will be, eye will be perceived here. Like that way, they have shown the areas of the sense of perception of the postcentral gyri. Similarly, the motor area is also same way presentation is there. In the precentral gyrus, that is the motor area. Similarly, sensory area also is presented like this. Now, lesion is loss of discriminative sensations of fine touch, movements and position of the part of the body, and crude form of awareness persists for the sensation of pain and temperature. Why this crude form of sensation is present? Because that is perceived at the thalamic level, whereas spine level is perceived in the postcentral gyrus. Therefore, there will be loss will be there. Loss will be there of the touch, temperature, pressure loss, sensation loss will be there. But a crude form of awareness can occur at the thalamic level. Next, somesthetic association area. In the parietal lobe, another area number 5 and 7. You can see in the diagram, this is the area number 5 and 7. Location, it is located in the superior parietal lobule. See, this is the superior parietal lobule. And in the precuneus, this is called as the precuneus in the medial surface. The precuneus is present. Precuneus on the medial surface. Now, what is superior parietal lobule? Superior parietal lobule lies between the superior medial border. See, this is the superior medial border. This is the superior medial border and intraparietal sulcus. This is the intraparietal sulcus. This is the intraparietal sulcus. In between the intraparietal sulcus and the superior medial border, there is the superior parietal lobule. And precuneus is a quadrangular area between the suprasplenial sulcus. This is called the suprasplenial sulcus. Why it is called suprasplenial sulcus? Because it is located above the splenium part of the corpus callosum. This is called as the corpus callosum, and above the splenial part of the corpus callosum, the suprasplenial sulcus it will be there. And in between the suprasplenial sulcus and the superior medial border, there will be area number 7 will be there, called as the precuneus. It is a quadrangular area located in the medial surface of the parietal lobe. Now, what are the functions of it? Functions of it is the analysis and integration of the information related to the general senses. Means whatever sensations you have perceived, whether it is a pin prick or whether it is a thorn prick, that all sensations, analyzing it, analysis of the and integration of the information related to the general senses are done here. That prick is due to the thorn, or that prick is due to the pin, or that pain in the wound is due to the knife. Means that perception of the various types of sensations with the previous memories which are there, it will be done in the somesthetic association area. The somesthetic association area it does the analysis and integration of the information related to the general senses. It's done here. And sense of the stereognosis. Sense of the stereognosis means ability to recognize the familiar objects by feeling, holding them in hand without visual aid. For example, if you have holding a cube without seeing it, you can observe that it is a cube. We can feel that it is a cube having 6 surfaces in it. Like that way, by percepting it, by perception of the touch sensation, will be responsible for the percepting the sense of the cube. That is called as stereognosis. That is called as stereognosis. And that stereognosis is mainly occurs in the somesthetic association area. Somesthetic association area. Now, what happens if lesions occur here? If lesions occur here, then a condition called as agnosia will occur. Agnosia means absence of understanding of sensory information. Whatever sensory information you have perceived, you can't understand it properly, whether it is a pin prick, whether it's a thorn prick, or whether it's a prick, that you can't perceive. That agnosia will occur. And astereognosis will be there. Person is unable to recognize the objects held in hand while the eyes are closed. I told example I have given that holding a cube, telling that it has 6 surfaces without seeing it. That is called as stereognosis. He cannot perceive that object properly. He is unable to correlate surface textures, shape, size, and weight of the object to compare the sensations with the previous experience. Why? Because integration is lost here. Analysis and integration is lost here. Therefore, that stereognosis will occur and agnosia will be there. Next, sensory speech area or also called as vernix area. Now, motor speech area is located in the frontal lobe, whereas the sensory speech area is there, area number 39 and 40. Area number 39 and 40, they are located in the supramarginal gyra and the angular gyra in the inferior parietal lobule. In the inferior parietal lobule, below the intraparietal sulcus, inferior parietal lobule is there, and inferior parietal lobule is divided into three parts by the upturned ends of the posterior rams of the lateral sulcus. Posterior rams of the lateral sulcus, and the superior temporal sulci also divides it, and the inferior temporal sulci also divides it. Now, anterior part, which is formed by the posterior ramus, it is called supramarginal gyrus. It surrounds the upturned end of the posterior ramus. See, here it will be. See the cursor of the mouse. That is the supramarginal gyrus will be located here. Middle angular gyrus. This is the angular gyrus located above the superior temporal sulci, which arches over the upturned part of the superior temporal sulci. This part, area number 39. Area number 39, it is the angular gyrus. The supramarginal gyrus and the angular gyrus are the sensory speech area, or also called as vernix area. They are the sensory speech area, or also called as the vernix area. Now, what are the functions of it? Functions of the sensory speech area is interpretation of the language through the visual and auditory input, through the eye and through the ear, whatever we have heard. Interpretation of the language done by that is done in this area. And this area helps us in understanding the speech and using correct words to express. It is essential for the process of learning, such as reading, writing, and computing. The reading, writing is lost if this sensory speech area or the vernix area, if lesion is there, then he cannot read or write. Sensory and motor speech areas exist together in one hemisphere only. Means if he is right dominant, that will be located in left cerebral hemisphere, and if he is left-handed, then it will be located in the right lobe of the cerebrum. The vernix area is connected to the Broca's area. Now you can see in the diagram, the vernix area is connected to the Broca's area by a bundle of nerve fibers called as arcuate fasciculus. That is an association fiber called as arcuate fasciculus. Now lesions of this, what will happen? Lesions will lead to sensory aphasia. Sensory aphasia means ability to read, write, and calculate is lost. I told it before. Ability to read, write, and calculate is lost. Speech is fluent, but he can talk fluently. But what word he uses he is unaware of the words he uses. But compression of the spoken speech is very poor. Grasping of the spoken speech is poor. And word blindness means inability to grasp written speech is present. Inability to grasp the written speech is present. He is unaware of the meaning of the words he uses. Now, lesions involving both Broca's area and vernix area results in loss of production of both the sensory speech also, as well as the he is unable to write, read, as well as he cannot speak also. That condition is called as global aphasia. That condition is called as global aphasia. He is unable to understand of the spoken speech as well as the written speech, and it usually occurs suddenly as a result of stroke or head injury. It develops slowly in case of the brain tumor also. Means global aphasia usually occurs if both the vernix area as well as the Broca's area, if both are affected, then the global aphasia will be there. Means he cannot express the speech also, and he cannot read and write also. The words which are heard, he cannot grasp it properly. The words which he has seen also, that cannot be grasped by him properly. That condition is called as global aphasia. It is lesions of both the broca's area and sensory speech area will be there. Next, taste area. Taste area, where it is located? It is located in the dorsal wall of the posterior arms of the lateral sulcus with extension into the insula. It extends into the insula, so into the central lobe also. It places the taste area adjacent to the first sensory area of the cortex of the tongue and pharynx. We have seen that the sensory area of the tongue and the pharynx is located in this area number 312, located here. Near to it, it is located. Function, perception of taste sensation. Function is perception of taste sensation, and lesions of it leads to loss of taste sensation. Loss of taste sensation will be there if the lesions of the taste area occurs. Next, functional areas of the temporal lobe of cerebrum. Temporal lobe of cerebrum, there is a auditosensory area is there. Temporal lobe of cerebrum is mainly related with ear. It is mainly related with ear, Shrotrendriya. Got it. Auditosensory area, area number 42 and 41. Where it is located? It is located in the anterior part of the upper surface of the superior temporal gyrus. It is located in the superior temporal gyrus. You can see in the diagram here, in the upper part of the superior temporal gyrus. And functions is it receives the input from the medial geniculate body. Medial geniculate body is a part of metathalamus. It is a part of metathalamus which is responsible for which comes in the pathway of hearing. It comes in the pathway of hearing, and through the medial geniculate body, through the auditory radiations, it receives the input. The medial geniculate body receives the input from the organ of Corti. Organ of Corti is located in the internal ear. Means in the cochlea, in the membranous labyrinth part of the internal ear, there is an organ of Corti is there, and that will be responsible for the perception of the sound. And the impulses which are generated will pass through both the cochlear nuclei, but mainly from the opposite side, it will enter into the medial geniculate body. And this area perceives the auditory information which comprises loudness, pitch, source, and directions of the sound also. Now, what happens if lesions occur here? Unilateral lesions of the primary auditory area result in slight loss of hearing because it receives auditory input from the cochlea of both the sides. Usually, the cochlea of both the sides will be communicating with the one side medial geniculate body. Therefore, a complete loss of hearing will not be there. Complete loss of hearing will not be there. But mainly the loss of hearing of the opposite side will occur. But loss will be greater in the opposite side. And bilateral lesions, if it occurs on both the sides of the lesions of the primary auditory area occurs, then complete loss of cortical deafness will be there. Causes complete cortical deafness is there. If both side lesions are there, if the both sides lesions are there, then complete cortical deafness will be there. Next, auditopsychic area. Next is auditosensory area and auditopsychic area. Area number 22. That is the area number 22. Location, it is located in the lateral surface of the superior temporal gyrus. You can see in the diagram, lateral surface of the superior temporal gyrus, slightly posterior to the primary auditory area, which it surrounds. Now, what are the functions of it? Name itself indicates that it correlates the present auditory information with the past experience and does the interpretation of sound which is heard. For example, if I have told A word will be stored, that sound will be stored in the auditory area, auditopsychic area, and whenever you heard the word A second time, at that time it can recognize it. This is A. Like that way it can recognize. That is the function of the auditopsychic area. That is the function of the auditopsychic area. Now, what happens if the lesions occur? Lesions occur result in inability to interpret the meaning of the sounds heard. Means if you tell him A, he can't understand what is, he can't hear what is A. And the patient may experience word deafness also. Auditory verbal agnosia, that is called as auditory verbal agnosia. This area is represented unilaterally. In right-handed persons it is in the left side, and vice versa. Vice versa means in the left-handed persons it will be on the right side. Next, primary olfactory area. That is also located in the temporal lobe of cerebrum, area number 27. In the inferior surface, it is located in the inferior surface of the temporal lobe of cerebrum. Location, it is in the piriform area. Say the piriform olfactory cortex is located here. That is the anterior part of the uncus and the para-hippocampal gyrus here. Piriform area, and one amygdaloid body, one part of the limbic system is called as amygdaloid body. It is comes under the basal nuclei also, amygdaloid body, and that will be located here. And its function is perception of smell. Its function is perception of smell, and lesion is anosmia. Its lesion is anosmia. Here, perception of smell is hampered. Perception of smell is hampered. Next, secondary olfactory cortex. Next is secondary olfactory cortex, area number 28. It is located in the entorhinal area. Entorhinal area means uncus and anterior part of the para-hippocampal gyrus. Uncus and the anterior part of the para-hippocampal gyrus. Para-hippocampal gyrus lies medial to the collateral sulcus. You can see that this is the collateral sulcus, and medial to the collateral sulcus, the para-hippocampal gyrus is located. And its posterior part is limited medially by the calcarine sulci, joined to the sigmoid gyrus through the isthmus. Now, what is uncus? Uncus is the anterior part of the para-hippocampal gyrus. Uncus is located here. It is the anterior part of the para-hippocampal gyrus, lies medial to the renal sulcus. Now, uncus as well as the anterior part of the para-hippocampal gyrus are the secondary olfactory area. And the function is perception of smell. Lesions occurs anosmia. There will be loss of smell sensation. Next is regarding the functional areas of the occipital lobe of cerebrum. Last is regarding the functional areas of the occipital lobe of cerebrum. Visual area is area number 17, mainly related with chakshurindriya. We can say that occipital lobe of cerebrum is related with the chakshurindriya, whereas temporal lobe of cerebrum is related with the shrotrendriya. Okay, visual area, area number 17. Location, where it is located? It is located in the walls and the floor of the posterior part of the calcarine sulcus. Means calcarine sulcus is located here in the medial surface, and near the wall of the calcarine sulcus, both superiorly and inferiorly, there will be means in the cuneus. This part is called as cuneus. This part of the medial surface of the lobe of the occipital lobe of cerebrum is called as cuneus, and here this part of the occipital lobe is called as lingual gyrus. Is called as lingual gyrus. Now, structural feature of the visual cortex is the presence of white striae will be there here, and hence the name it is called striate area. This area is also called as the striate area. And not only that, in the occipital pole of the occipital pole, there are three poles are the frontal pole, occipital pole, and temporal pole in the cerebrum. In the occipital pole also, the visual area will be there. Now, what are the functions of it? It receives and perceives visual information, which comprises the form, size, color, transparency, illumination, and movements of the object. And macular area has a largest representation. Means the macula is the spot in the retina where only cones are present. And that will be deeper. That area will be more visual field will be there, located in the calcarine sulcus of the macular area. Therefore, usually lesions of the near the calcarean sulcus, the macular area will be prevented. Macular area will be prevented. Now, unilateral lesions of the superior wall of the post-calcarean sulcus, if the superior wall of the post-calcarean sulcus results in inferior quadrantic hemianopia. Inferior quadrantic hemianopia. See this diagram, the inferior part, the superior, whatever visual field is in the superior will be represented inferiorly, and whatever visual field is there in the inferior aspect will be represented superiorly in the visual area. In the visual area. Therefore, that will lead to a condition called as inferior quadrantic hemianopia with macular sparing. The macular part will be prevented from the lesion. Now, bilateral lesion, unilateral lesions of the inferior wall of the calcarean sulcus. Unilateral lesions of the inferior wall of the calcarean sulcus result in superior quadrantic hemianopia. Superior quadrantic hemianopia will be there if the inferior wall of the calcarean sulcus, means the superior part of the visual field is lost. Lesions of both superior wall and the inferior wall will lead to contralateral homonymous hemianopia. Contralateral homonymous hemianopia means a part of visual field seen by both the eyes is lost. In the visual field, a part of the visual field seen by both the eyes are lost with macular sparing. And lesions of the visual cortex usually occur due to the thrombosis of the posterior cerebral artery, a calcarean band, and the visual cortex presenting macula is spared because this site where posterior and middle the arteries means posterior cerebral arteries which are there, they will meet here. Posterior and middle cerebral temporal arteries will meet here. Therefore, this area is prevented from thrombosis. Next, visual association area. Visual association area is the area number 18 and 19. Now it is located where it is located. It surrounds the visual area except anteriorly. Here it is. It surrounds the visual area. Function it correlates the visual information received with the past experience and enables recognition and appreciation of objects once seen. It enables the assessment of distance and orientation of an object in the space. Lesion, usually visual agnosia will occur. Means comparison of the present sensory information with the past experience will be lost. For example, if you have seen a needle, that memory will be stored in the area number 18 and 19. And when you see the needle again, you will grasp that it is a needle. You will grasp that it is a needle. But what happens if the visual association area lesion is there? Even though if you have seen the needle, you can't grasp it what it is. You will be thinking it is as if seen for the first time, as if seen for the first time. That is called as visual agnosia. Thank you for listening, and I thank the organizers for providing me an opportunity to explain regarding the functional areas of the cerebrum. Thank you. If you have
Thank
any
you very
doubt,
much, sir, for taking your time to prepare for such an extraordinary enlightening session, which was incredibly informative. We will now go ahead to the question and answer session. Shall we begin, sir?
okay.
Delegates, please post your questions in the chat box. Delegates, please post your questions in the chat box. So till now, there are no questions raised. Let's wait for a few more minutes.
Okay.
Delegates, please post your questions in the chat box.
Okay. Ask questions. Unmute and ask.
So we have a question.
Sir, sir, good
For
evening, doctor.
Spashan,
Good evening.
Okay, good evening.
Sir, in vertigo cases, major assignments can be mostly advisable or otherwise symptomatic treatment is required.
Actually, vertigo cases, there will be the semicircular canals as well as the ampullary part of the semicircular canals are affected. There is a special area in the cerebrum is not present. The special area for the vertigo is not present, but it is usually occurs due to the imbalance in the ampullary part. There will be a cristae and maculae like that way. Some in the membranous labyrinth, there will be cristae and maculae part are there, which are responsible for the perception of the equilibrium. Mainly in the semicircular canals as well as in the vestibule part of the internal ear.
Is there any manipulation of exercises for say head exercise, head and neck exercises?
I have no idea about exercises. I have no idea.
Okay. Okay, doctor. Thank you. Thank you, sir.
Thanks.
so we
Welcome.
have a couple of questions.
Okay.
For Sparshan Indriya, which area should be considered?
Sparshan Indriya, usually the post-central gyrus, area number 3, 1 and 2 in the parietal lobe of the cerebrum, there the perception of the pain, touch, temperature, pressure, as well as the stereognosis all will occur there. Area number 3, 1 and 2 of the post-central gyrus in the parietal lobe of cerebrum. I will show the slide. See, here, area number 3, 1 and 2. See the cursor of the mouse. Area number 3, 1 and 2. That is related with Spashanendriya.
Okay, sir. So we have another question.
Okay.
What should be suggested for a child of 7 years who have autism and is hyperactive?
Treatment point of view, I have not gone in detail. As an anatomist, I have told regarding the functional areas. Treatment point of view, I should go with that.
Okay, sir. We have another question too.
Okay.
If Ati Nidra continues more than 2 months, is there any Manasa imbalance?
Atinidra, actually, there is a system is there called as reticular activating system. In anatomy, ARAS, ascending reticular activating system is there. There are some of the nuclei there located in the brain stem, which are responsible for the arousal. And when we take caffeine or when we do when we are tensed, this ascending reticular activating system is stimulated. Whereas even the alarm voice of the alarm also, as well as light also, that will be stimulating the ascending reticular activating system and makes us awake. To bring sleep, actually, we should reduce the ascending reticular activation of the ascending reticular activating system. we should reduce the activity of the ascending reticular activating system. And that can be brought by reduction in coffee or reduction in switching off the lights. Not only that, hearing voice disturbance also should not be there. Then we can go to nidra. If we get ati nidra, then we should stimulate the ascending reticular activating system.
Okay, sir. So we have another question too.
Okay.
What lesion leads to parosmia?
Parosmia. Actually, lesions of the olfactory areas itself will be leading to that condition, but I have not gone in detail about the parosmia.
Okay, sir. Delegates, you can please post your questions in the chat box. Sir, we have no more questions left.
Okay.
Once again, thank you, sir. It was really an informative session.
Okay. Thank you.
Now,
I thank all the organizers to providing me an opportunity. Thank you.
now I invite Dr. Anjana Ma'am, Assistant Professor of Department of Sharira Rachana, Ayurveda College, Coimbatore, to deliver the vote of thanks.
Thank you. Good evening, one and all. On behalf of Ayurveda College, Coimbatore and Team DIKSHA, it is my privilege to deliver a vote of thanks today for our respected speaker, Dr. KrishnaMurthy sir, on the topic functional areas of cerebrum and its applied aspects. Thank you so much, sir, for sharing your valuable knowledge on this difficult topic regarding neuroanatomy. And I'm so happy as I was his student during my PG days. So attending his class was once again a happy moment and reminded me of his wonderful classes he has taken us during embryology and his excellent dissection classes. Thank you so much, sir, for accepting our invitation and delivering today's speech within such a short span of time. Thank you so much. I extend my sincere gratitude to the whole Diksha team for providing us with the best virtual platform. Let me thank all our delegates who have responded so well to make this session a successful one. We look forward for your participations in the coming session. Thank you all. Thank you once again.
Thank you.
Thank you, ma'am. It was great listening to you, sir. I express my heartfelt gratitude to our guest speaker who had managed to join us despite his busy schedule. Thank you, sir. In the end, everything will work out, and if it doesn't, it's not the end. Stay healthy, stay safe. We have come to the end of the session. To more about our updates, please to stay connected with our social media platforms. Thank you to all the participants and wish to see you all in the next session of Dr. Sudhiraj and Memorial Webinar Series by Ayurveda College, Coimbatore. Thank you all. Have a great day.